According to World Health Organization, malnutrition and hunger are considered to be rampant among displaced populations and refugees. Currently, around 40 million people across the globe comprising of infants, children, adolescents, adults and older people suffer from one or multiple forms of malnutrition. To help address these challenges, nutritionists and dietetics are needed in roll-out of food aid programs among other humanitarian interventions. Thus, undertaking a certificate in human nutrition and dietetics at Humanitarian Global gives you in-depth knowledge and understanding of Introduction to Nutrition. In this module, you get introduced to nutrition as a topic, learn the principles of nutrition, nutrition assessment and primary healthcare. Secondly, nutrition in the lifespan. You get to explore topics about the human anatomy and physiology, nutrition in convalescence, nutrition for pregnant and lactating mothers and nutrition in the elderly. And thirdly, meal planning. Get an introduction to meal planning, food safety, hygiene, non-communicable diseases and how to diagnose nutrition in a community. Apply for this course today by visiting our website www.humanitarianglobal.com for more details.
My name is Annette, I'm a nutritionist, and I welcome all the participants for today. Our session is on interventions, nutrition interventions. So I will begin. The session is high impact nutrition interventions. And just before we start the session, I would like to say that in this session, we are going to cover many areas which are practiced in the humanitarian sector. So it's like an overview of what many of us who are nutritionists or other health professionals, health workers, all the things that we do to help with the nutrition problem there in the community, in our humanitarian sector. So it will be good for us to know what we are involved in, and many of us are involved in one or more of these interventions, which are equates to areas. So to begin with,
Annette, you can share the screen for us to see.
Okay. So I hope you can see the screen. Can
Yes,
we see
you
this?
can.
Okay, then we begin without wasting time. So this is our topic, high impact nutrition interventions. Today, we expect to learn the following. How to explain what is a nutrition intervention very briefly, to describe some interventions targeted at different groups. So we will, in this session, we are going to deal with a few of them. We will deal with interventions targeted at the young infants, that is from birth to 6 months, interventions targeted at infants and young children, that is from 6 to 23 months, interventions targeted at malnourished and HIV-infected children, interventions targeted at women of reproductive age, interventions targeted at pregnant and lactating women, and then we are also going to mention one or more, about one global intervention, so that you just have an idea. So we start. I have a small definition here for the purpose of our session, although we can always go in details in our modules. So we are defining the nutrition intervention as the purposefully planned actions that are intended to resolve and improve on the nutrition problems. So here in nutrition, we find that primarily we deal with the nutrition problems. We resolve them, we treat them, we manage them so that the people can remain healthy. So that is what a nutrition intervention, what we do so that we can solve those problems. So we improve this nutrition at both the health facilities and the population levels. And we are happy to work together with the World Health Organization, who have, in collaboration with the UNICEF, they have proposed some effective and nutrition interventions, which we are going to look at today. And these interventions have worked best when they have been combined with other interventions which reduce infections, such as the water, sanitation, and hygiene. I also want to draw your attention to what we call the essential nutrition actions. I've highlighted there. Maybe you should go and also learn further what is essential nutrition actions. These essential nutrition actions have been paramount. They are very important in improving the health, especially of the vulnerable groups, that is the infants and the children, and also of the pregnant and lactating women. So in our session today, we will be talking so much about essential nutrition actions, and that is why I would like to mention what are these essential nutrition actions before we proceed to the specific interventions targeted at particular groups. So these are the essential actions that protect, promote, and support the priority nutrition outcomes. You have heard of them. So they include, there are 7. They include exclusive breastfeeding for 6 months, from birth to 6 months, adequate complementary feeding starting at 6 months, with the continued breastfeeding for 2 years or beyond, appropriate nutritional care of the sick and malnourished children, adequate intake of vitamin A for women and children, adequate intake of iron for women and children, and adequate intake of iodine by all members of the household. So these have been the essential, meaning they have been there and they have worked and they have been incorporated in our health system and have been called essential. They have been practiced everywhere in the world. So now we proceed to the interventions which are targeted to specific groups. So number 1, we are going to look at interventions that are targeted at the young infants. And these are the people in the group of from birth to 6 months. In other literature, they say from 0 to 6 months, but I don't believe there is anybody who is 0 age. So we like to say from birth to 6 months. So the interventions that have taken place to solve and to enhance the health of this group, the problems of nutrition of this group, is to make sure that there is early initiation to breastfeeding and exclusive breastfeeding. Those are the 2 main ones. So early initiation means starting to breastfeed immediately after birth, that is as soon as possible. Normally, we used to say within 1 hour of birth, but as soon as possible, even if the mother is able, if the infant is ready, you just put the baby, as that picture can indicate there. I hope you can see this picture. You place the baby near to the mother, skin to skin contact, and you let the baby find the nipple and they start breastfeeding. So this initial initiation, early initiation, is very good because the baby gets the mother to produce the breast milk immediately, including the colostrum, that is the first milk that is very rich in immune factors, and it also lets the mother have a flow of milk. Now, exclusive breastfeeding is also a global recommendation for infants. This one we look at it in the area of infant feeding, but it's also an intervention that has made our infants very healthy. Now, there are some actions that have been put in place to protect, to promote, and to support breastfeeding. So those actions are 4. I want to mention them. The first one is the International Code of Marketing of Breast Milk Substitutes. Now, this is like an international health policy that promotes breastfeeding. The code is a set of recommendations that regulate the marketing of breast milk substitutes, feeding bottles, and teats. The aim of the code is to stop the aggressive and inappropriate marketing of breast milk substitutes. At this point, I want to say that breast milk substitutes is anything that is marketed to be or recommended to represent partial or a total replacement of breast milk for an infant. Anything that is not breast milk, but it can include things like commercial formula, animal milk, anything that may be marketed to replace breast milk. That is what this International Code of Marketing stops. We don't market. And I believe you'll tell us at the end of the session in our various countries where we come from in Africa and other parts, if you have seen, whether it's on the television or on social media, that is marketing any sort of replacement for breast milk. It has been stopped so that we ensure that babies are breastfed. So the other action is that promotes breastfeeding is the maternity protection at work. And that is to ensure mothers have adequate time to breastfeed their infants. So there is maternity protection. It's a law. It has been reflected in the international labor standards of the International Labor Organization. And this one sets out basic requirements for maternity protection at work. Many countries have adopted this. They have ratified the Maternity Protection Convention, that is number 183, and some of its provisions are adopted in many countries. That is why we see mothers who are breastfeeding, they have paid leave when they are working. Of course, we will also share at the end of the session, the maternity leave also includes the paternity leave, and it's different in different countries, with the most African countries having a 3 months maternity leave, others places having 6 months, just to promote breastfeeding for the mother. The other action that promotes exclusive breastfeeding is the baby-friendly hospital initiative and the baby-friendly community initiative. So these baby-friendly initiatives, they are global initiative of the World Health Organization and the UNICEF that aim to give every baby the best start in life by creating a care environment that is in the hospital and community that supports breastfeeding as the norm. So right now I have some steps that are included in this initiative. So there are some 10 successful steps that promote breastfeeding that are implemented in the hospitals and in the community. And I'm about to share with you here as follows. So these steps are 10. The first one is putting in place the hospital policies. You can see those, the first picture there. And some of the things when we are putting in place the hospital policies, we look at, we say that there is no promoting of infant formula, bottles, or teats. We make breastfeeding care a standard practice in the hospital or community. And then the policy also enhances on keeping track of support for breastfeeding. We follow mothers to make sure that they still breastfeeding up to the recommended time. The next step that hospitals support mothers to breastfeed is by ensuring that the staff is competent. So we do that by training the staff on supporting mothers to breastfeed. And then we also assess the health workers' knowledge and the skills. Do they know? Do they have adequate knowledge on breastfeeding? Do they have skills that they can teach to the mothers on breastfeeding? We do that by training them and assessing their knowledge. The third step in the baby-friendly initiative is we put in place antenatal care in the hospital and some outpatient centers there. And here we help the mothers discuss the importance of breastfeeding for babies. And then we also prepare mothers on how to feed their babies in the antenatal care. Fourth step, it is the care right after birth, and it includes encouraging skin-to-skin contact between the mother and the baby soon after birth. And why is this skin-to-skin contact important? First of all, it enhances the bonding. Two, it promotes exclusive breastfeeding because the baby will start breastfeeding immediately and help the mother produce milk. And then it calms the baby feels safe and warm, and they cry less. So it's like welcoming the baby to the world with them, without making them feel like it's a very foreign world, the arms of the mother. So skin to skin contact is really encouraged. And then also helping the mothers to put their baby to the breast right away after birth. That is what we are saying is the care right after birth. And then another step in the baby-friendly initiative is to support mothers with the breastfeeding. You know, this is something that we do. We do that by checking the positioning, the attachment, and the suckling. The mothers practically how to do it. And then we help mothers with common breastfeeding problems, you know, any problem that they may have, inverted nipples, engorged or cracked nipples, all those sorts of problems, infected nipples. We help them how to deal with those problems. And then number 6 in the baby-friendly initiative is that the hospital support mothers to breastfeed by supplementing. We talk about supplementing. We tell mothers that they should give breast milk alone unless there are medical reasons. And then if there are any other reasons that mothers cannot breastfeed, we give priority to donor human milk in case we needed the supplement. And then we also help mothers with them who want to formula feed on how to do so safely, because some mothers may choose for some reasons that they want to use the infant formula. We help them on how to do it. Rooming in is another step in the baby-friendly initiative, whereby we support mothers in letting the mothers and babies stay together day and night so that they can bond. And then making sure the mothers of sick babies can stay near their baby. That is why you see in most hospitals, they provide mothers of sick children with a place to stay so that they can also be near the sick child. And then there is responsive feeding that is also implemented there in the baby-friendly initiative. And here we do that by helping mothers know when their baby is hungry. You know, especially new mothers, they ask so many questions. How will they know the baby is hungry? We tell them how to recognize signs of a hungry baby. And then not limiting breastfeeding times. You should breastfeed the baby on demand and for the period of time that the baby needs to breastfeed. All that we support the mothers by informing them that. And then we inform mothers in step 9 is also another step about the bottles, the teats, and the pacifiers. We counsel the mothers on the use of this and the risks of feeding bottles and teats and pacifiers. In short, we discourage them because of the likelihood for infection. When we are not able to clean up this stuff properly, it may cause infection to babies. And if they must use them, which we highly discourage, we help or we show mothers on how to sanitize them properly. And finally, the baby-friendly initiative also talks about what to do when you're discharging a mother from the hospital or a community-based center. And we say we support the mothers by referring them to the community resources for breastfeeding support, and also working together with the community to improve breastfeeding support for services. So far we have looked at those 3 actions that promote breastfeeding. The first one, we said, without just going back, but so that we don't get lost, we said that we do not advertise breast milk substitutes. We give the mother the maternity leave and also the fathers. And the third one, we have said, we have introduced the baby-friendly initiative. And the fourth one here, we support breastfeeding also by counseling and supporting the mother at both the community and facility level. So we do that by counseling. We do a lot of counseling on breastfeeding, the importance of breastfeeding and how to do it during the pregnancy, immediately after the childbirth, and also during the postnatal period when the mother comes for the clinics. And we also pay special attention to the parents, to the mothers of low birth weight. Remember, a low birth weight is a baby who is born below 2,500 grams because they need more catch-up growth, how to feed them. Some are not able to feed properly. We give more counseling and support for these mothers, including the very low weight. Those are babies who are born below 1,500 grams. You see, that's a very tiny baby. And also for the preterm babies, we take care of their, including we do counseling on the mothers and parents on infant feeding in the context of the HIV virus. How do they do it or what not to do? So that is included in the support of breastfeeding, where we do counseling to all these mothers. Now, I would like to move to number 2. These are interventions. We have cleared interventions for the new babies, that is from birth to 6 months. Now we move to interventions targeted at infants and young children who are between 6 months and 23 months of age. There are many. I decided to make a list here so that we don't get lost here. In this group, we have so many interventions. We'll pass through them. So they are as follows. We look at complementary feeding, how to improve complementary feeding, and home fortification of food with micronutrient powders, vitamin A supplementation, iron supplementation, zinc supplementation, iodine nutrition of management of children with severe acute malnutrition, management of children with moderate acute malnutrition, the nutrition care and support for HIV-infected children, 6 months to 14 years, and the nutrition care and support during emergencies. So there are interventions that I'm going to mention of this age group. There are very many. So we start with the complementary feeding here. And complementary feeding, just to remind ourselves, is a process starting when breast milk or infant formula alone is no longer sufficient to meet the nutritional requirements of the infant. And therefore, other foods and liquids are needed along with the breast milk or a breast milk substitute. So here we continue breastfeeding as we introduce complementary foods to meet the adequate nutritional requirements of the babies. So this is done between generally from starting 6 months until 23 months. You continue breastfeeding at least until 23 months, that is until 2 years. And beyond, sometimes it's also allowed, if you can, the child can also continue breastfeeding beyond there. And this one, we are just mentioning here that it prevents the malnutrition of this group. And remember, if we prevent malnutrition, it prevents all other health issues, including diseases, including disabilities and other complications, and including even death. So I've just captured and said there that it prevents malnutrition, so it's a heavy word. So how do we promote? What are the actions that have been put in place to promote complementary feeding? First of all, we counsel and support the mother on how to do appropriate complementary feeding. And we do this in facilities, that is in hospitals and health facilities, and also at the community. And we also do this by training our staff to make sure that they deliver the proper information. And we also advocate for continued breastfeeding and the utilization of the locally produced food. During the counseling, we tell these mothers to make use of the locally produced foods. We show them how to use them and balance them. And then the second action in this group is home fortification of complementary foods with micronutrient powders. Now, when we introduce complementary foods, sometimes these foods may not deliver adequate nutrients, especially micronutrients. So it comes a time when we are to use or to make these foods nutritionally adequate by the use of powders. And here I've said, especially in lower income settings, where the child's diet may primarily be plant-based, you know, and this is a common phenomenon in Africa. We feed our babies with a plant-based diet, you know, the tubers, the cereals, and this, we do not forget that they have a lot of anti-nutrients. They have the phytates, they have the oxalates, they have the tannins, all those anti-nutrients that interact with the micronutrients, especially the minerals, and make them unavailable for absorption. So as much as we like a plant-based foods, it also has some disadvantages. It may decrease the micronutrients, especially the nutrients that are being absorbed by the baby. So we have put in place an intervention whereby in such settings, there is supplementation with these micronutrients in form of powders, and they help us be sure that the child's food has adequate nutrients. Now, these micronutrient powders, they are used at home, point of use. So we give the mothers these sachets and they add them to the food of the child at home at the point of usage, and they are used on an everyday basis to ensure that we prevent these micronutrient deficiencies. So the micronutrients have been very useful in reducing anemia and iron deficiency in young children, as they can be added directly to food. And they are available in small sachets, which are packaged in a very good way that they resist temperature and moisture. So we can see them here as we look at the actions. So this is just for, you can have a picture. This is a cup of porridge that has been prepared for a child of that age group, 6 to 23 months. Then we can see the caregiver here is putting in some powder from a small sachet into the porridge, which will be mixed. So this is the micronutrient powders. And these micronutrients include so many micronutrients, actually about 13 to 14 of them, which we can always look in detail when we are doing infant feeding. So the actions that have been put there is to do nutrition assessment of these children. And then when we do the nutrition assessment, we are going to evaluate the nutrition status of the children and find out if they need the micronutrient powders. And if they do need the micronutrient, now we prescribe them and give them to the mother to use and train the mother on how to use them at home. And we have seen that this has really prevented the micronutrient deficiencies like anemia and even vitamin A deficiencies. If we do not give the micronutrient powders, we can always provide some fortified complementary foods. And also we do deworming, although we are nutritionists, dietitians, but we work together with the other health staff, the physicians, to do things like deworming for the children. Remember, deworming has a consequence on nutrition because the parasites, the worms, what they do is that they interfere with the nutrients of the child because they are going to interfere with the digestive system and cause internal bleeding, loss of blood for the child that might end up getting anemia and other complications. You know, when a child has worms, he also has diarrhea, that is loss of nutrients, and generally not happy, loss of appetite, which will interfere with the food intake. So that's why we do this in collaboration with the other health staff. The other intervention in this group is vitamin A supplementation for the children who are under 5 years. And the World Health Organization recommends that in settings, and I want us to be a bit keen here, it's not everywhere that vitamin A supplementation is given, but it is recommended in infants and children who are 6 to 59 months of age as a public health intervention to reduce the child morbidity and mortality. So this vitamin A should be given twice yearly, that is after every 6 months. And normally it is a high vitamin. You know, when we give children, for example, you will hear that at 6 months, we give children about 100,000 international units. Here beyond that, at about 12 months, we start giving children 200,000 international units. That's a high dose, and that is why it's given biannually. And we are being told we do this because a single high dose is highly absorbable. And once it is absorbed, it is stored in the liver as a fat-soluble vitamin. And the liver mobilizes it over an extended period of time as needed. So that is why we just give twice per year. Now, the actions that have been put in place to promote vitamin A supplementation for children 6 to 59 months are, we have an integrated vitamin A supplementation for infants and children into our national health policies and routine health services. So we have integrated this into our national health policies and routine health services. For example, through the biannual special days where supplementation is combined with other child survival interventions. Here I have a picture, a very recent, what we are talking here about, an example of what we have been doing. Like now here in Kenya, in the place that I live in, not the whole of Kenya, I can tell you that we have been involved and we are still going on until the end of this month. And this is our advert, which we have put place, and we are saying that there is vitamin A supplementation from 30th of May to 30th of June in 2022. And we are saying this is for the children aged from 6 to 9 months and wherever they are found. We will be visiting the schools, the early child development centers, the households, and even the health facilities in our sub-county. So you will see this even in your country because vitamin A supplementation has been implemented in the national health policies. So that's an action to promote that vitamin A. The other one is iron supplementation for children 6 to 23 months. Now these children, because they grow very fast, they have a higher iron requirement. And normally the children are born with an adequate store with enough to last them for the first months of their life. And the rest they get from the breast milk. But as they grow older, beyond the 6 months, the iron content in breast milk is not sufficient to meet the infant's requirements. And because of the unfortified complementary foods, which are normally low in iron, this group is very susceptible to iron deficiency. We also want to mention here that the low birth weight and preterm infants, they also have this problem of iron deficiency, because first of all, they are born with fewer iron stores. Remember, they didn't grow to term, they didn't add weight enough, and therefore they have a higher risk of developing iron deficiency, anemia at a young age. So that is why we do iron supplementation for these children 6 to 23 months. So we can do a daily supplementation, or we can do intermittent doses. So in the settings where diet does not include fortified foods, remember we already talked about micronutrient powders. If we are not putting micronutrient powders in the foods of children, meaning that we are not fortifying them, or if the diet is not fortified and it's not a healthy diet, then, or the prevalence of anemia in that area of children at approximately 1 year of age is severe. And we know that by saying that the prevalence of anemia is above 40% in this age group of children who are about 1 year, the supplements of iron should be given to all the children in that area who are from 6 to 23 months of age. Now, we may choose to give a daily iron supplementation, or we might do intermittent doses. And this means once, twice, or thrice in a week on non-consecutive days. We give on this day, skip the next day, and then give on the other day. That's what we mean. And this will help to improve the iron stores and prevent anemia. And remember, the consequences of anemia are serious, because we do not have enough hemoglobin. The work of hemoglobin, is to transport oxygen to all parts of the body. And without oxygen, we cannot have optimal growth. So that is why we are very keen on iron in this group. The actions that have been put in place to promote the iron supplementation for this group is we do nutrition assessment, and any child who is diagnosed with anemia is put on iron supplementation for every day until their hemoglobin concentration return to normal. In malaria endemic areas, that is where we have malaria, we treat malaria in conjunction with giving iron supplements. And also in areas where there is hookworm prevalence, because we have already seen the worms cause intestinal bleeding, loss of blood, we also combine with the iron supplementation for the children. Zinc supplementation is also another one, and it has been very successful over the years. We have saved a lot of infants, a lot of children who suffer diarrhea. In Africa and other developing countries, the lack of safe water and sanitation remains a problem, and this causes diarrhea. And that is why diarrhea is the second cause of death in the world for these children who are below 5 years. And the intervention that has been put in place is to treat this diarrhea with zinc and oral rehydration solution, ORS, and this has reduced the death. And also supplementation of zinc, we have seen, in fact, many people have known this during the corona period, has also reduced respiratory diseases such as pneumonia. So zinc supplementation, when we are dealing with diarrhea, has become an intervention that we do. So the actions that have been put in place is to integrate the use of zinc and ORS, oral rehydration solution, for diarrhea treatment in national health policies. And of course, improving the outreach service and service linkages, and to implement clean water, sanitation and hygiene practices, and exclusive breastfeeding, and also to make the population aware. Nowadays, we have seen improvements. The zinc, as you can see in this picture, this is a zinc co-packaged with the ORS. You can see this package here, the one I'm pointing at. It comes with the zinc tablets and the oral rehydration sachets, the ones that you put with clean, you mix with clean water and feed the baby slowly or the child slowly to prevent hydration. And this is the zinc that helps the absorption of fluids and also strengthen the immune system of the child. So they are co-packaged together and they are provided when we are managing diarrhea in the children. And it has been a lot of help in preventing the death of children from diarrhea. We also have optimal iodine nutrition in young children. And this is especially done, the supplementation with iodine is usually implemented in areas where we have not had this universal salt iodization. You know, it had been a recommendation of by the health bodies that all the countries should have a universal salt iodization program, but it's not everywhere where we have iodized salt. So iodine is very important because it helps in the optimal brain development of the fetus and the young child. And that is why we are saying it has to be adequate in the diet of the child and of the mothers who are pregnant. In the cases where we do not have enough iodine, or we do not have universal salt iodization, we provide the iodine supplements for the pregnant and lactating women. And also we provide the supplements for these people, for the children, and the complement may be fortified with the iodine for the children who are in this age group of 6 to 23 months. Now, okay, we have not included the actions here because it's clear that the action to promote enough iodine in everybody's diet is for every country to adopt a universal salt iodization. So that's why I have not written the action. You can get it from there. And then we have the management of children with severe acute malnutrition. I will not also dwell so much on this. Remember, our last session was on IMAM, where we are dealing with management of severe acute malnutrition and of moderate acute malnutrition. And here, the WHO and the UNICEF already have put in place the area of identifying children with the SAM. We said it's those with weight for height, which is below -3 standard deviation, those ones with bilateral pitting, edema, those ones with a MWAC of below 115 millimeters, and the ones without an appetite. So these children are managed in patient management, and the action that has been put in place to make sure that some severe acute malnutrition is managed is the adaptation and implementation of the protocol for facility-based management. This is, we have seen every country has its version of IMAM that we looked at the last session that I was with you. So WHO has worked together with many countries and together with other organizations to implement these protocols. And we have seen that we have been able to manage the severe acute malnutrition both in the facilities, and we have also included community-based management of severe malnutrition, where we have put some facilities out there in the community within the routine of the health system, and also a lot of health staff training has occurred. And that is how now we have been able to manage such a child. You can see this is the same child after 5 weeks, they have been able to regain their nutrition status. Then there is also the outpatient management of children with severe acute malnutrition that has been put in place. And we are saying many children who are 6 months or older with severe acute malnutrition, but they have an appetite and they have no medical complications, they can be managed in the community in an outpatient facility, meaning they are not admitted. And these children, we are saying they can be identified in the community before the onset of the complications. This can be done by the community health workers using the MWAC tapes and checking the bilateral edema. And then when they are identified now, they can be managed using the ready-to-use therapeutic foods until they gain their weight to the recommended levels. So the actions that has been put to have this in place is to follow the WHO has put in place the international standards for manufacturing of the ready-to-use therapeutic foods. And this has increased the local production because now there is a formula and there is a way that you can follow this, making this ready-to-use therapeutic food very available in the worldwide. And of course, the staff, us included, we have been trained on how to provide these ready-to-use therapeutic foods. You can see this picture here. The child is using the ready-to-use therapeutic food, and you can see this is the community health worker, the health worker there, or the nutritionist, who is looking to see how well the mother is feeding the child. And they are not in a hospital, they are out there because it's outpatient, is in the community. So those are some of the actions that have been put in place. Management of children with moderate malnutrition is also another intervention that has been put for this group between 6 months to 5 years. Moderate children with moderate acute malnutrition have been identified by using this criteria, where their weight for height is between the Z score of -3 and -2, and they must not have edema. And the dietary management intervention that has been made there is to counsel the children and their guardians, the guardian of the children, to use for optimal use of the locally available food, how to prepare the meal, how to feed, so that they can be well again. And then we also supplement, do supplementary foods, and we are saying we can supplement them with the rations, especially where there is food shortage. We can give them food rations. And for the children, we also provide sachets, which are similar to ready-to-use therapeutic foods, but these ones are called ready-to-use supplementary food. We give them 1 packet of 1 sachet each day. Okay, we give them many and then advocate that they use 1 sachet per day to complement what they're using. And it is usually having about 500 kilocalories and a lot of nutrients. So in conjunction to what we give them as food rations and the available food, they can now be healed or treated of the moderate malnutrition that they have. So the action that have been put in place to support management of moderate acute malnutrition is the promotion of breastfeeding, counseling for families, improving the food security, by providing conditional and unconditional cash transfers to support the agriculture, such as agriculture or crop diversification, making sure that people plant many types of crops for feeding. And we continue to do research on the composition, acceptability, and use of supplementary foods. So those are some of the actions that are being put in place. And for the HIV-infected children who are from 6 months, 14 years, we first of all recognize that they have additional nutritional needs because of their HIV status. They need to grow and develop, and they are also having a condition that may necessitate them to have more nutrients and energy. So they are very vulnerable groups. So the interventions that have been put in place are always provided in guidelines that have been worked out already by the World Health Organization and other bodies. And these national guidelines have been adopted by every nation, and they have been localized to prevent and manage malnutrition in case of HIV. So I'm aware that here in Kenya, we have national guidelines for the management of HIV. I have seen one every country has, so that is what has been done. And we teach this in depth when we are doing prevention to mother to child HIV, and when we are feeding the child in the context of the HIV. And then we have the nutrition care and support during emergencies. And here we've just commented, we cover this very well in our module, nutrition in emergency. But we are saying here, any disruption or displacement of populations in emergency situations will have a great impact on the health and nutrition status of the infants and the young children. And we usually apply the essential nutrition actions that we were mentioning so that we can improve the maternal, infant, and young children nutrition with such actions such as providing ORS with zinc, vitamin A supplementation, addressing acute malnutrition, and any other intervention that may improve the nutrition status. We do that during emergencies. Now, in the emergency context, displaced or devastated communities are often dependent on the provision of food aid, which we are also concerned in nutrition emergencies. We prepare a food basket that is locally, that is adequate and acceptable, and provide these communities with rations. Some of the actions that are carried out in infant and young child feeding emergencies include early emergency response, that is where we ensure the infant feeding in emergencies has been taken care of. There are operational guidances that give full details on how to implement infant feeding in emergencies, and we follow that. And the major thing is that breastfeeding, exclusive breastfeeding, together with offering complementary foods, is provided. And then we have minimal level of response, which include giving a general food ration for all the infants and the young children, and also doing supplementary feeding for pregnant and lactating mother. And also we have another action where we prevent micronutrient deficiencies by giving multiple vitamin and mineral supplements to vulnerable groups. All this, you are not to worry about it because we cover in details in nutrition in emergencies, but those interventions have been put in place. And then, I hope we are still together. Eric, can I continue or do we answer some questions?
Maybe you can answer can see we have 2 questions, as I also encourage our participants to send us more questions. So you can start with the two that are present. I know they'll keep on sending more questions.
Okay, thank you. Before I move to the intervention for women of reproductive age, I'll answer 2 questions that are here. One is from Isaac, and he's saying, in a scenario where the mother delivered and the mother is not producing breast milk on spot due to some hormonal interference, what can we feed the new baby on? That is in 1 to 2 days after birth, since BMS is not recommended. Isaac, that is a good question. Now, in case breastfeeding is not possible at all, maybe the mother has died, maybe they have a medical complication, whatever it is, and we cannot feed a baby on breast milk, the first option is usually donor breast milk. That is why in our facilities, we have donor milk from other mothers who have excess breast milk. They have done it, we have checked it, we have pasteurized it. That is usually the first option. In case there is no donor breast milk, we can consider a wet nurse. A wet nurse is another mother who is breastfeeding and who has been found to be healthy. And we can have this mother breastfeed this child if they have adequate breast milk. If that is not available, we go to the third option. That is, we use the infant formula, the commercial infant formula for newborns. That is what we do. After that, now, if it is we are in a situation where we don't have that, and then we might need to use modified animal milk, which is not encouraged, but now the baby cannot die if there is no other option. That is the other options in that order. So I hope I have answered that. And then the same Isaac has asked another question. In what context do we give micronutrient powders to the children 6 to 23 months? I may have answered there in the many notes that I'm giving, but I can point out that micronutrient powders are given to children to ensure nutrition adequacy. So if we suspect that the diet of the child does not have adequate micronutrients, and how will we ensure that? Are they feeding on enough animal source foods? Are they feeding on enough vegetables and fruits? We will rule out by checking their diet and maybe performing some laboratory tests. And then if we find that they have some deficiency of some micronutrients, and in most cases we can tell through their diet, the quality of diet, then now we prescribe the micronutrient powders. In some areas, we just give them as the general population because we know in a certain slum, in a certain emergency, in a certain area, children cannot have adequate nutrients, especially micronutrients. So we give these micronutrient powders and they are added to foods to make sure that the children have now adequate micronutrients. I hope I have also answered that. Thank you. There is also another question here. What nutrition from Simon Agongo is asking what nutrition intervention is put in place in terms of high prices of food in the market where an individual or a household cannot afford. Okay, that is a good question. It is very common now here in Africa because of the rate of inflation that most households cannot afford to buy nutritious food. So we as nutritionists, he's putting this question to us, what nutrition intervention may be put in place. I have a few suggestions, maybe other people could also suggest. Now, in places where there are high prices of food, some governments may not even afford to, subsidize these foods. And so what we can do is teach people on sustainable agriculture. And that is why we are seeing even in class, in our curriculums today, we are teaching students on how to go and teach the community on kitchen gardens, on utilizing the space that they have, whether they are the verandas or the small pieces of land that may be there. We are seeing people planting things in tires, in tins, in sacks. So that is one way. And then we can also have people learn on how to budget the little money that they have. We can tell people on how to acquire alternative foods that are cheaper but more nutritious than the choices that they have. If you cannot afford animal foods, probably it would be a good idea that you invest in poultry. Keep a few chicken there, or buy a few eggs and feed them to the people who are not able to afford the expensive food. So the question I can have there is just a suggestion, is for people to plant or to acquire some animals that they can keep so that they can produce their food to consume. And then there is another question before I go on with the presentation. Is it possible for the lactating mothers to transmit disease to their child through breastfeeding? That's a good question. Yes, it may be possible for some diseases to be transmitted through breastfeeding. A good example is the HIV. If the mother is HIV and they are not aware, they are not taking any antiretroviral therapy, it may be possible that they may transmit this HIV to the child and other viral diseases. So what we do is ensure that during postnatal care, we check the nutrition status of the mother. How is she feeling? Does she have any disease? Because it is possible that some diseases can be transmitted. And where the mother is using medication for some disease, according to the physician, there is some medication that may be transferred through breast milk. There is some medication when the mother is using, the physician will advise the mother to not lactate for a period of time, while another one, they will tell the mother it's okay to breastfeed. So the short answer is yes, it is possible for some diseases to be transmitted through breast milk. And that is why we also treat donor breast milk. When we get it, we pasteurize it for ensuring that we have killed any germs that is there in that breast milk. Now, another question is what nutrition intervention is put in place in times of high, okay, that one we have answered. I've tried to answer, I've said, I think people should grow their own vegetables and look for other sources of food. Somebody is saying, Vilma, lately I've noticed a lack of the micronutrient powder. Is there a way we can enrich babies' foods for the underweight babies? Okay, first of all, in instances where there is no micronutrient powders, we advocate, actually, first of all, we advocate for a balanced diet. The reason why we are giving micronutrient powder is because of the nutrition inadequate of the diet. So we necessarily not need to use the powder if the diet is nutritionally adequate. So we just make sure that there is an animal source food there. It's a balanced diet, and then there is some fruits and vegetables and all that, and adequate starchy food there. The child will be okay. And then somebody is there a way we can enrich baby food by the underweight babies? Okay, for the underweight babies, that is what they want to ask. Yes, by making food nutrient dense. I'll just give a small example so that you can get a picture. What is a nutrient-dense food? Now, if I have a cup of porridge, ordinary porridge from the cereal flours that we use, and I want to make it nutrient-dense, I may add some sugar there, I may add some oil, and then I give the baby. So they are not just taking the normal porridge, there is added calories because of the sugar and because of the kind of oil that I've put there. Is it butter or whatever I've put there? So that is how you can make a baby add weight. Give them energy dense, not nutrient, energy dense foods. Now, please allow me to go on with our presentation before I answer more questions. Eric, is that okay?
We can continue, and thank you for answering the questions.
Okay. Now, the intervention that has targeted at women of reproductive age is, these are, just to be clear, these are anybody who is menstruating. So this can be a doctor plus any other woman of reproductive age. So now this group, because of loss of the blood, monthly blood loss, we have an intervention that has been put in place where we advocate that they have intermittent iron and folic acid supplementation. And this one avoids, and that is why WHO has advocated that they be supplemented with IFAS, iron and folic acid supplementation. Remember, we already know intermittent means give once or twice or 3 times a week on non-consecutive days. And we have seen in some countries where they have very good health programs in their countries, we have seen even programs for adolescent and reproductive health. We have seen in some schools, in high schools, in some colleges, that the young women there and the young girls have been told to collect some IFAS for supplementation. They have been educated on. Now, my friend tells me, friend living in some developed country, that is a norm there, that anybody who is of a woman of reproductive age, that they take this IFAS routinely. So that is advocated for, to avoid anemia, which is, the prevalence of anemia is very high in our country. So which are the actions that have been put in place to promote the use of IFAS or iron supplement in pregnant? Okay, I have not looked at the action that has been put in place to promote the use of iron and folic acid for women of reproductive age, because we are also covering it here for interventions targeted at pregnant women, because even them, they need to use iron and folic acid supplementation. So we will look at the action collectively. So for pregnant women, it's recommended as an intervention to prevent anemia. It is recommended that they have a daily iron and folic acid supplementation, because iron requirements are increased during the pregnancy. Remember, in pregnancy, by the end of the pregnancy, now, moderate or severe anemia during pregnancy has been associated with, if somebody has anemia during pregnancy, they have a risk of premature delivery, maternal and child mortality, and also an increased risk of infectious disease. So that is why iron supplementation is very important in pregnancy. So the daily oral iron and folic acid supplementation is recommended as part of the antenatal care in the and the middle term. From this is here, we advocate that every pregnant woman take IFAS. Sometimes it's even advertised on our TVs. And for intermittent use of iron and folic acid supplements by non-anemic. In some setups, in some countries, we are so sure because of the nature of the developed country that the woman is getting adequate diet. But just to be sure, what we do is that we give a little bit of iron this day and that day, but not daily, iron supplementation, just to make sure that the woman has enough. The actions that have been put in place to promote IFAS in pregnant women is the integrated program of antenatal and neonatal care, where the iron and folic acid supplementation is given, and where screening of all women who attend the antenatal care takes place. They are screened for anemia during the antenatal and postnatal visits. And then in malaria endemic areas, whereby people are also likely to suffer with some iron deficiency, the treatment of malaria goes together. It is implemented in conjunction with measures to prevent, diagnose, and treat malaria during pregnancy. They go together with the iron and folic acid supplementation. In pregnant women, there is vitamin A supplementation. Now, this occurs is of severe public concern. And the reason why vitamin A is very important is because it helps in cell division, in the fetal organ and skeletal growth and maturation, the maintenance of the immune system, and the development of the vision of the fetus, as well as the maintenance of the maternal eye health and night vision. So, WHO has published a guideline indicating that vitamin A supplementation is not recommended during pregnancy as part of the use of the supplement is only recommended. Note that it is only recommended in where there is a severe public health problem related to vitamin A, because excess vitamin A is also dangerous for the pregnant mother. Actually, it can cause a lot of problems. So that is why we have to be sure there is a vitamin A deficiency in a certain locality before we give the supplementation. Then we also have calcium supplements in pregnant women. Now, WHO recommends the supplementation for the pregnant women with elemental calcium in areas where the dietary calcium is low. And for women who are at a high risk of developing hypertensive disorders, the pregnancy. There has been a very clear evidence that shows the daily supplementation with the risk of gestational hypertension, preeclampsia, and preterm birth. So to prevent preeclampsia, hypertension, and a problem that involves the placenta, where the baby now might not be able to get adequate blood, that means nutrient and oxygen from the mother, it's dangerous because it's a hypertensive problem that may affect the placenta. There's those small vessels that involve the exchange of stuff from the mother's blood to the child. This problem has been seen to be a big risk. So the use of calcium is being used to prevent this. And sometimes it works. So it has been put there to help the mothers. Then the pregnant mothers are also required to have optimal iodine. And we are also saying supplementation is recommended where the salt has not been iodized. And these supplements are given to the mothers or the foods in that locality, the foods that are being used by the pregnant women should be fortified with iron, because we have already seen iodine, very important because it helps with the optimal brain development of the young child. You know, it prevents the condition that is called cranitism. We can check later when we are doing macronutrients of the deficiency disorders caused by lack of iodine. In short, if a mother who is pregnant with a baby does not have enough iodine, it is going to cause some growth retardation and developmental with the baby, even maybe being disabled. The babies that are born are not normal, and that is why it is very important that we give them. There is a intervention that I want to mention, because we have finished with the intervention targeted for the pregnant women. Here we have seen there is iron and folic acid supplementation. We have seen vitamin A supplementation in pregnant women, calcium supplements in pregnant women, and iodine supplementation in pregnant women. And to end this session today, I want to talk one global intervention where there is fortification of the flours of our staple foods for the general population. We have seen the wheat and maize flour fortification is preventative food-based approach to improve micronutrient status of population over time. We have seen this being done. If you look at a packet of your wheat or your maize flour, or whatever flour that is staple, you can see that it has been fortified with nutrients. Now, the major micronutrients that are the flours are iron, folic acid, vitamin B12, vitamin A, and zinc. Although other micronutrients be included, but the reason why these are included is because they are the micronutrients of public significance in the developing countries. So this is our end of the session. Before we interact and share what we know, all of us here, I just want to say that all these interventions that we have mentioned are not all the interventions that we do in nutrition and dietetics. There are others that I have not mentioned, but for the sake of time in our session, I have chosen to mention these ones that are very common, and we are calling them high impact nutrition interventions, because high impact here means that they have tremendous effect on the health of populations, and then they cover a lot of people in terms of age groups and in terms of the population. So they have, in short, we can say they have reduced so many deaths, so many diseases from so many people. They have improved health situation. Without these interventions, you can imagine how many people we would have lost in our world. So that is why we are calling them high impact nutrition interventions. And we have said there are others. Now, all these, by now I know you are realizing all these things that we are calling interventions in the places you work, in what we do in our humanitarian world, in our facility-based nutrition care and dietetics. All this involves interventions. Our main work is handling nutrition problems for the populations at different levels. And we can have an in-depth coverage of all these interventions and more in such areas that are found in our training modules that include maternal and infant young child nutrition, that also include infant and young child feeding, infant and young child feeding in emergency, baby-friendly community initiatives, prevention of mother-to-child transmission, guidelines on nutrition and HIV, nutrition in emergencies, integrated management of acute malnutrition or community management of acute malnutrition, and many, many more. So if you ever want to learn more, just get in touch with us, and then we can have you enroll in one of these areas so that you can be more proficient. Thank you for the session. Maybe Eric.
A wonderful presentation.
Thank
I
you.
can see a few more questions on the Q&A.
Okay. Let me answer them.
Yeah, and I also encourage us to keep on sending the questions so that our key speaker is able to answer them.
Food and Agriculture Organization of the United Nations states that malnutrition and food insecurity have contributed to an increasing frequency of crisis events as well as vulnerability of many communities across the globe. Nearly half of the world's population suffers malnutrition, yet there is little official development assistance that goes to nutrition. Hence, there is a need for training more humanitarians to help them acquire right knowledge and understanding needed to administer good nutrition and diet to millions of people across the world. Undertaking a diploma in human nutrition and dietetics prepared by Humanitarian Global gives you in-depth knowledge and understanding of nutrition care process. In our first module, you get to learn and understand the nutrition care process, general body metabolism, nutrition epidemiology, assessment and surveillance. Secondly, components of nutrition. In the second module, our participants get to tackle topics including micro and macronutrients, nutrition in emergencies and non-communicable diseases. Thirdly, diet therapy and meal planning. In the third module, participants also get to learn about diet therapy, meal planning and food production for invalids and convalescents. Fourthly, environmental and public health. In the last module, the learner will get to learn more about environmental health, nutrition in public health, measures of morbidity and mortality and communicable diseases. Apply for this course today by visiting our website www.humanitarianglobal.com for more details.
Okay, before I answer the question, I would like us to have also some interactive session because I'm answering all the questions shortly. There are not so many. Maybe some people can tell us in their country, because we are from different countries. Let me just hear from some people who will tell us what is the maternity period recommended in their country.
Yeah, I can see some hands up. Jamal? Jamal? Hello, Jamal, are you there with us? I think I can see Malesi. You can unmute your microphone. As we wait for Malesi, I can see a few answers on the chat section. Lydia from Nigeria, Alinda, Nelson Mandela, are you there with us?
Yes, good morning.
Morning, sir. How are you?
I'm doing good.
Yeah, maybe you can get to answer the question.
Sorry, I joined the session late because I was a little bit committed, and just why I could not be in time. Yeah, so at least I'm able to capture some of the slides.
Yeah.
And then I'm seeing a lot of abbreviations there, and then I did not notice how those abbreviations can be put in full. And just why I was seeking for clarity so that at least I will have the idea about it.
For the abbreviations, we are going to be explaining them in a few minutes. But also when we send you the slides, we are going to have them in full name. Yeah, thank you for that, Nelson.
Thank you.
Annette, I think from the chat, I can see Isaac saying in Somalia, it is 4 months long.
Okay, let me go to the chat. So Okay, from Somalia is 4 months. That is good. That's very good.
Yeah, then Linda said Nigeria is 3 months also.
Okay, that's like Kenya. Kenya is 3 months, okay.
Yeah, I can see Abel says in my country, Liberia, mothers are given 6 months of paid maternity leave.
Wow, that is very nice. I think
Yeah.
we should move there. That's wonderful, because
Yeah,
that means
that is really
the mother
wonderful.
will, yes. Liberia is 6 months. That's very good. Paid maternity leave.
Yeah,
And
thank you for
as we
that,
answer,
Abel.
we could also answer the paternity leave. Mention also the paternity leave. Do we have leave for the fathers?
I can see a few more comments. Elizabeth from Cameroon says it is 3 months.
Nice.
I have Marvin Nafula, Uganda is 3 months.
Okay.
I have Blaze from Ghana saying that is also 3 months. I have Joshua Dominic who says in some parts of Nigeria, it's either 2 or 3 months. Yeah, Liberia 6 months. Yes, Emmanuel Mangok Deng saying South Sudan is 3 months. Same as Sila talking about maternity being 3 months and it is paid. I have a dollar saying paternity leave in Liberia is 5 days. He also confirms that maternity leave for maternity is 6 months, paternity is 5 days.
Okay.
I have Eunetu, I hope I got your name right. Ethiopia is 4 months, that is pre-1 month and post 3 months. I have Said saying that Somalia is 40 days. Elizabeth again saying in Cameroon, they do not have paternity leave.
Sad.
Yeah, I also have Daniel again saying paternity leave in South Sudan is a week.
Okay.
I can see Zoe from Madagascar, 3 months. Zoe, is that paternity or maternity? That should be maternity. I have someone from Mauritania, 2 months. Marvin from Uganda again, paternity is 5 working days. That's 1 week. Okay. I have Cloud, Congo Brazzaville, maternity leave is 3 months. Yeah, I think we can see the differences.
Yes.
Yeah, which are a bit wide.
Okay.
Yeah, thank you, participants, for just letting us know of the different number of days you get for maternity and paternity in your respective countries.
Okay, thank you very much for all those responses.
Yes.
As we can see, that there is a paid paternity and maternity leave. And what we should advocate for, because we are nutritionists and we are advocating for breastfeeding, exclusive breastfeeding, is to be like Liberia for the 6 months. In some developed countries, which we are not really going to name here, they have a paid maternity leave of 6 months because they recognize the importance of breastfeeding. So let me go now to answer some of your questions. I don't know, I'm going to leave you in which page there so that you can be, so I answer the questions. So
the last person we had answered from the Q&A was Vilma.
Wilma, so let me go
our next
back.
person should be the question by Kahia.
Okay, Kahia. Yes. Yes, I have seen that. Kahia asks, what if the mother is the main source of the family? I mean, that's like the breadwinner of the family. What advice would you give since the mother is away from her child, or sometimes leave her child with a caregiver or a house helper? Okay, my suggestion here would be to express her breast milk. You know, you can do that using 3 ways. You can breastfeed manually, just using your fingers. And now I don't know how to describe that, but there is a way you express milk from the breast using your fingers, or the mother could also use a manual pump, breast pump, or an electric breast pump. But the thing is, they can express their breast milk. And this milk should not, if it's not refrigerated in where we don't have a fridge, it should not last for more than 8 hours. So the caregiver now, what they do is they heat some water, and then they put the milk in a container and put this milk in a container in the hot water for some minutes so that it can be warm. You don't heat it directly because you don't want to kill the live immune factors. And then now they can feed the baby. I would advocate that they feed the baby using a cup and spoon, or a cup, because we are discouraging the use of teats and feeding bottles, which are very hard to clean. And in most cases, if not properly sanitized, they are the main causes of diarrhea because they are not very clean. So I hope I have answered that. The other question is from an anonymous. Can micronutrient powders be given to sick children? The short answer to that is yes and no. It depends how sick they are. Very malnourished children, if they are severely malnourished, we may not give these micronutrient powders because in severe acute nutrition with the medical complications, we don't give iron. We wait until the medical complications are resolved before we give iron. Now, if the children, depending on their disease, that is why I say yes and no. If the children are sick but they are not malnourished, it could be advisable to enhance their diet, to make their diet nutrient rich by adding some micronutrient. But I would advocate, I would suggest that you check with the physician or the pediatrician who is attending the child, depending on the sickness, the degree of sickness, then you may give the child. The only caution I would give, do not give to severely malnourished child, but any other child, I would think it would be okay, but it would be good to check with the physician. But let me just talk about the sick child. The most important thing to do with a sick child who is below 2 years is to offer breast milk. Breast milk is usually very important for sick children. They handle it better than food, and it gives them their nutritional needs. Even if it's not enough, it's very important. The little they may get from the mother, because they're already big, it may improve their nutrition status and health status more. So I hope that is an answer that you have answered, Kahinya. There is Muhammad Abdi Salad. They are saying thank you. Thank you too. Okay. With much respect, I inquire you a couple of questions. That's okay. Regarding the low birth weight intervention of nutrition, based on your experience, which intervention is the minimum required to use as to gain appropriate weight? As well, what sort of track mineral, I think he means what sort of mineral elements are essential to give the low birth weight baby? Now, the low birth weight baby is a common problem. First of all, I'll start by defining what is a low birth weight baby. We said in terms of kilograms is a baby who is born with a weight below 2.5 kilograms, and a very low birth weight baby is a baby who is below 1.5 kilograms. So these are babies who are not, who have not been fully developed in terms of weight. So they are underweight. That is what we are saying. So the best food to offer these babies is usually breast milk. If they are clinically stable and they can breastfeed, that is what we do. We put them on the breast and make them breastfeed. And because they do not have enough strength to breastfeed, the mother has to be there keeping on breastfeeding slowly by slowly until this baby can get adequate milk. In cases where they cannot breastfeed, we help the mother express the breast milk, and then we can feed the baby by use of tube feeding, because they are not strong enough to suckle. So we make sure that now we tube feed, that is nasogastric feeding to the baby. And as long as they are getting adequate breast milk, believe it or not, if they have any other medical complication which should be treated, they will gain weight if they have adequate breast milk. In absence of the breast milk, we say through any oral feeding route, either breastfeeding or through the nasogastric feeding, we can also give infant formula. In absence of the breast milk from the mother, we can give donor milk. In absence of the donor milk, we can give the infant formula. That is how we feed the low birth weight baby. If they are not able to suckle, I've said give them through the tube feeding, and if they have enough, you can be sure they will gain weight as long as they have no other medical complication. And then in the same question, I'm capturing, they want to know which mineral elements are essential to be given to the low birth weight baby. Now, if the baby is getting enough breast milk, all the minerals that the baby gets from the breast milk are adequate for that low birth weight baby. But as they grow, we have seen one of the deficiencies that they may suffer now after 6 months may be iron deficiency, sometimes even calcium deficiency. We should be keen. In short, is that low birth and preterm babies, we should keep on monitoring their mineral content in their blood plasma and give whatever it is that they don't through the supplements. But if the mother is feeding a proper diet and her breast milk has everything, the baby will get from there. Okay, the other question is, I hope I have answered that. Where is the other question? From Isaac Ibrahim, if a child meets the required routine immunization of childhood for the first year of his life, that is BCG and polio and all the other measles vaccines, what is the resolution for him to obtain the missed doses? That's also a good question. Okay. I must say I'm not an expert in immunization, but I would suggest that take the child to the nearest health center and indicate that they have missed those immunizations. I'm aware there are some time-limited immunizations. If you don't have it within that time, then you cannot have it. And there are some that can be done later in life or whatever, the earliest period. So for that question, I may say I cannot really answer and say, if they miss BCG, they should do this and this. If they miss polio, they should do this and this. That one, I'm not very conversant with immunization, but we can always get an answer for you later through the rest of the team. Remember, we are many health practitioners here. I will find out from my colleagues. So Isaac Ibrahim, I'm going to have you emailed what can be done. Even our next session, we can also refer to that. Now, let me just answer the other question, if you allow me. What's the problem caused by excessive vitamin A? Is it in pregnancy or anywhere? Okay, in pregnancy, it's excessive vitamin A is very dangerous in pregnancy because remember, vitamin A is a fat-soluble vitamin. It's stored in the body. So if a mother has excess, one of the things that can happen there could be a spontaneous abortion. It can cause spontaneous abortion, or the baby could have been born with some congenital problems, especially those that involves the cardiovascular system and function of the heart, of the central system. So that is why we do not give vitamin A supplementation without establishing whether there's a need for it. It could cause a lot of birth defects, including the heart and even the central nervous system. And worst of it, it could also cause abortion for the mother. So me, I've taken that in the context of the pregnant mother. So I didn't specify the question. The other question is, thanks for your excellent, valuable information. Thank you too. Okay, that is a comment. The other question is, supplementation is not recommended in pregnant women because it is also the what is not true, otherwise what will be the dose. Now, Zoe Laveloson, please rephrase your question or your comment. It's not so clear to me, please. And then there is another one. What's the rationale for the modified milk? Mother Zioka wants to know more about the modified milk. Now, I think she's referring to breast milk substitute, where in the absence of the donor milk, in the absence of the formula milk, you may need to use animal modified milk. I think that's what she wants to know about. And she's asked what is the rationale. The thing is, the baby must survive. So in case you are found in a situation, and we do not recommend this, is only that is a life-saving thing. In case you are found in a very remote village and you are the health worker there, and there is a mother who unfortunately is not there for some reason or who is sick, and there is a newborn who has been there, and there is no any type of breast milk or the formula milk, then what would you do to that baby, a newborn baby? So that is why we come up with these formulas, not that we recommend them, but it's as a last resort, where now there are recipes that exist that can modify animal milk or some UHT milk or some sort of milk other than condensed milk. We do not work with condensed milk, whereby you dilute with some very clean water, you add some sugar, and then you can use the milk. So I can only say that depending on the age of the child, you can dilute this animal milk after boiling it to kill the germs with clean water, and you can add some sugar, but it will never, it will never be equivalent to the breast milk because it lacks all the adequate nutrients in a proper ration, and it also lacks the immune factors. But as a lifesaver, as you do something, as you transport this baby or you get another alternative, that is something that probably can be done to save the life. So that is what I would say.
I can see a question by
And yeah, ask by hand.
Lix Miller. Question asks, should a malnourished child still be given the live attenuated vaccine?
Oh, okay. Yes, yes, that was the next question. Severely malnourished child, can they be given the live attenuated vaccine? The answer is it's advisable that you have a healthy child to be vaccinated, especially where you may be using some modified live vaccines. Because in very weak children or in sick children, this vaccine can actually cause the real disease. So in my opinion, we should have a child who is fully healthy, who is not malnourished and who is not sick, being given the vaccine. That we are talking about the live attenuated vaccine, because even in its very weak form, with a child with very low immune or who is already having a compromised immune, it may affect them. So I would suggest that we treat the child for malnutrition or any disease, and then we give the vaccine later on. Do we have any other question?
I think I can see Laura Nasimiu. Oh, that one is okay. Laura, we are going to get back to you on that one. I think those are all the questions so far. I think we can now jump into the session where they get to ask us questions. And I can see we have Jacob Garang. Jacob, are you there with us? You can unmute your microphone. Jacob, are you there with us?
Yes, I am. I am Eric. I am Anthony, I mean.
Yeah, thank you. You may ask your question.
Yeah, thank you for the session and all the participants also who have been asking questions. It is very developing and it is good we are learning from each other. My question is already like having been explained, but there's a part that I'm not getting better. Yeah, like you said earlier that it is good to give this as iron folic acid supplement to lactating women, or rather to women who are menstruating. But assume if the woman is menstruating and as well as having an infant who is suckling. So will this supplement not interfere with the health of the child? That's what I was just asking. Thank you.
Okay, thank you very much for the question. I will first want to point out some points. It's possible to have a woman who is lactating and at the same time she's menstruating, but in most cases, if you do lactate properly, the menstruation is going to cease. You're going to have no menstruation. Now, I want to answer in two ways. For women of reproductive age, every end of month, every monthly period, they lose quite a significant amount of blood. Sometimes diet is not enough. It's not adequate to catch up with the production of new red blood cells or take and whatever. So it's an intervention that has been put in place based on scientific research, because research has been done and it has been established that many women of reproductive age are anemic, turn out to be anemic. So just to avoid this public problem, that is why we advocate intermittent iron and folic acid, the IFAS supplementations, to avoid this group from iron deficiency anemia, and we know the reason. Now, for a breastfeeding mother, let me just answer. Some of the iron that the baby is going to get is going to come out from the breast milk. So that is why postpartum, the nutrition status, the iron status of the mother should be established. And if it is not up to the proper amounts, the mother should be also put on IFAS to make sure that her breast milk is also adequate with iron, because the baby, her infant, is getting the iron from her. So is that clear? So Jacob, is it a little bit clear on what we are saying about IFAS, that we are doing it based on, the recommendations are based on evidence, that on current research, continuing research that has been conducted by health organizations that most women of reproductive age are usually on the borderline of anemia or anemic. And we already know the reason is because of the loss of blood every month. That is why, to prevent this problem of anemia, that is why we give the supplementation of iron and folic acid. Those are very important in making new red blood cells. I was asking if it is clear. If it is, maybe we can have another question.
In fact, it is very clear. Thank you. We can carry on with the session.
Okay.
Thank you, Jacob and Annette. I can see we have Dolo. Dolo, are you there with us? Dolo, you can unmute your microphone. Okay, Mohammed Salad.
Yeah, thank you, Eric. How are you? All of you, good
Mohammed,
afternoon.
how are you doing?
Can you hear me?
Yes, I can hear you.
Okay, thank you very much. And Anita, how you are just presented there, obviously very effective and excellent and a valuable presentation you are just giving us. So my question just regarding to the immunization, and as we know, the immunization and the nutrition, good nutrition go hand in hand. Vaccination prevention disease usually is TBs of marginalized nutrition children into malnutrition state. So as we know, malnutrition can be the overweight and underweight. The topic, my question is just, or I think the presentation also talks about the malnutrition, particularly undernutrition. So malnourished children are more likely to be die from the different infection diseases such as diarrhea, measles, and pneumonia. So which intervention can you just, Mr. Anita, again, definitely appreciated to be prevent or to be intervene as to minimize these the poor diseases or poor infection diseases. Thank you very much.
Okay, thank you for your question. Just to be sure of what I have captured from the question, you are asking about the interventions that can be put in place to prevent infectious diseases for malnourished children. Is that what you're asking?
Yeah, absolutely.
Okay. Now, malnourished children, as you have said, and I'm glad that you have pointed out, they are more vulnerable to infectious diseases and other type of diseases because in the first place, when they are malnourished, their immune system is weak. Malnourished child has a higher risk to infections than an unmalnourished child, and not just children, even adults. The more healthy adults are not so vulnerable to diseases just like unlike the ones that are malnourished. So what are the interventions that have been put in place to prevent infections? So first of all, it is to avoid situations that these children can come across infections. So first of all is observing total sanitation and hygiene, keeping you keep them away from infected people or people who have come in contact with infected people of any illness, infectious disease. That is why you see, if you go to a pediatric ward or in a child treatment center, everybody who works there is wearing some gloves and is wearing some mask to make sure that they do not contaminate this child. So in a home setup, and I don't know why they should be at home if they are malnourished, they should not be exposed to every Tom, Dick, and Harry. All the relatives who are coming to see the sick child should not see this child because they can transmit some infectious disease. Now, on the other hand, we work on strengthening the immune system. First of all, we look at their diet. And that is why we said, for example, if they have diarrhea or they have any other disease, zinc is being given to this child with one of the functions of strengthening their immune system so that they can fight the parasite that is causing diarrhea, so that they can fight the microorganism or the pathogen that is causing respiratory disease. So you give this child a very well-balanced diet. And if they are of eating complementary food, that is why you check their diet, you give them a nutrient and energy dense diet, probably that is very clean to avoid infection. And then the other thing you do, if they are 6 months and below, make sure that they are breastfeed more regularly. By the way, all the sick children, we recommend that is why we recommend that the mother stays with the sick child. We recommend more breastfeeding than before. Make sure that the child breastfeeds more regularly, more amount than usual, so that they can get more nutrients and energy, and so that they don't get dehydrated from the mother. So those are some of the interventions that I would recommend for preventing infections from a severely malnourished child. The target is improve their malnutrition status. Once they are well, you may now put them for immunization for some of those infectious diseases if they exist. So that is the answer. I hope it's satisfactory.
Yeah, and thank you, Athena. So obviously, I have one more question regarding to the low pathway, if it is Eric just accept.
Okay.
So far, the low pathway intervention definitely is a nutrition based on your experience. Which intervention is required to use as to gain the weight, as well as you are just mentioned the exclusive breastfeeding. Does it the exclusive breastfeeding is enough for the low path weight of babies? And in time is more than lower than 2 kg or lower than somehow 1.8, 1.2 kg kilogram. So far, and another question is as well as what sort of the track mineral element is that essentially to give the low path babies. That's it.
Okay. So the first component of your question you're asking is exclusive breastfeeding enough? Is it adequate for a low birth weight? And the answer is yes. As long as the baby is able to consume enough breast milk, they will catch up with weight more than fed on anything else. Actually, it's only that I could not present the whole thing, and that is why we are saying we have a more detailed, in-depth infant feeding where we cater specific groups. But I'm telling you that for any low birth weight, as long as we are able to feed them with enough breast milk, they will catch up with the weight. They don't need anything else. Because the more we feed them with other things, they do not have a developed GIT system, that is gastrointestinal system. They cannot be able to digest anything better than the breast milk. So that is why we are insisting that is the best type of food that we should give. And that is why I'm saying, if they do not, the mother is not there for some reason, we can consider giving this baby a donor breast milk or a wet nurse. In case there is no both of that, then in the third option, that is where we consider the infant formula as a third option. Otherwise, the best is the breast milk. If you give them enough, they will catch up. That one I've answered. As for the trace minerals, if there is any minerals that are needed for the low weight babies, what we do, we monitor these babies very closely. So we usually do some laboratory tests, and we monitor their nutrient status, especially some key nutrients. We check for some mineral status. In case they don't have enough, that is the only time we can supplement the trace minerals. And I've said that some of them that may be there, some low birth weight children are born with an inadequate iron stores because they have not been able to store iron, and other nutrients, including vitamin K, including any other micronutrient that may be deficient. We only supplement after doing a laboratory test. Otherwise, if you give them breast milk adequately, they will catch up with weight. So I hope I have answered that. There is another question in the Q&A question I would like to answer before somebody else asks a question. And then
That's okay.
Somebody is asking, Louis, I hope I have pronounced the name well. They're saying, hello for being invited. And then they're asking, they are from South Sudan, and they are working for an organization called Action for Recovery and Transformation. That's nice. And they're asking, can you please clarify the dangers of mixed feeding with infants less than 6 months? That's a very good question. We usually cover that in our other module, but just to give a short answer. Now, mixed feeding is when, in addition to breastfeeding, you are giving other breast milk substitute. You may choose to give breast milk together with animal milk or some infant formula. So the first obvious danger is if you do not exclusively breastfeed, the mother will stop producing enough breast milk, because remember, the more you breastfeed, the more the mother produces you stimulate the mother to produce more breast milk with the more the baby is breastfed. So if you don't breastfeed regularly, the milk is going to, important breast milk is going to reduce. Now, when you start feeding the baby with other breast milk substitutes, the digestion of these breast milk substitutes, I give a very short answer, may not augur very well with the baby's digestive system. They may have some inflammation. They may have some types of gastrointestinal issues, constipation, because when a baby is born, they do not have a fully developed digestive system. In the various infant formulas that we have, even sometimes when we say that you can have your baby feed on infant formula, we don't just feed a baby on infant formula without some advice. We advise the mothers who must feed the baby with infant formula to try a certain type of infant formula, because the components are not the same. If you read the tin, the tin label, you are going to see the components, that is the proteins, the fats, the sugars, the amounts are not the same. The types are not the same, despite the fact that they are all allowed. So sometimes digestive issues may result from either the animal milk and where the baby is not able to digest the types of protein that is found in animal, the casein that is found in animal or the infant formula, in comparison to the type of protein that is found in the mother's milk, and this may cause problems. So that's the answer that I would give, that the danger of mixed feeding is reducing the mother's production of milk and also causing some gastrointestinal problems, constipation and diarrhea and inflammation for the baby. So stick to one type of breastfeeding. Remember, we are advocating exclusive breastfeeding. So that's an answer that is there a question that is there in the Q&As. Now somebody wants to know, Muhudin Kahia wants to know, please explain more on donor milk, breast milk. Now, in hospital facilities, depending on the countries that we have, we have the donor milk, centers for donor milk. Here in Kenya, we have few. I don't know in your specific countries whether you have. Now, this is basically what happens. In a maternity ward, in a labor ward, in whatever, in a hospital where mothers have given birth to their babies, to begin with, some mothers have a lot of milk. You know, very young babies don't breastfeed a lot. So instead of discarding this milk, these mothers are encouraged to donate the milk. So they express the milk. First of all, they are determined their health status. You know, several tests have been done on them. Remember, they have been in that hospital. And then they donate this milk. And then there is a form of pasteurization. I cannot tell you the exact temperature why the milk is pasteurized. It has just a disadvantage that some of the nutrients and some of the immune factors may be damaged, of course, by heat treatment of milk, but otherwise the qualities of the breast milk remains good. So that is what is being collected in hospital facilities. Here in Kenya, we have several, and normally the women who are there at the hospital immediately after giving birth, and they are there before they leave the hospital, they donate the milk, and it can be used to help other babies whose mothers are not able. Maybe other people here, they can also explain to us what goes on in their country. So that's what I can say about the donor breast milk.
Annette, due to time, I think we can allow us just to have one last question. And then for our participants, we can provide you with an email where you can send us the questions. And we're going to get back to you. I think I can see a question by Rahila Midala, who is asking, in what situations will all of these interventions be implemented?
Oh, okay. Now, the interventions that we are talking about today are usually implemented in different programs. Right now, we are here, we work for different organizations. You may find yourself involved in one program of an intervention. An intervention, actually, we implement this intervention in several programs. You may find yourself working with a certain group, implementing a certain intervention. So it is not a matter of what time are they, it is what program you're working. The purpose of having our session today was to notify you as a nutritionist of the kind of interventions that you may be involved in your career. So in case you are just stationed in a CCC, you know, where we have comprehensive care program where we deal with the HIV infection, you should also be aware that today you may be in that area, you may be in that program, you may be in that project, but you may be working in another NGO that will make you work with another type of intervention. So today we were familiarizing you with the various interventions that occur. For your interest, if you want to become a good nutritionist, maybe you can work even with bigger organizations. When interview comes, you can pass. And by the way, I needed to tell you a small story before I started. The reason why we came up with this presentation for today, it was, we were trying to answer a question for our former student who got in touch with us, and they were just getting in touch telling us that they went for an interview and they passed. And therefore we asked, and so what were the questions that were asked? They asked, there was one that was very tricky. They asked us to mention some interventions, nutrition interventions that can be practiced or applied when you are working for a humanitarian organization. So they wanted to know some high impacts. So we decided this could be a question that some of you might have come in, you might come across when you are doing some interview, and just for your general information, that is why we are yourself working with a program that is implementing in any of these interventions. Thank you. That is the answer. And before I end, I feel I should answer this question. There still are some more questions, but because of time, let me answer this question. Somebody is asking, which time is appropriate for introducing complementary feeding? Is it on the exact date of the child, 6 months complete, on the exact 6 complete months, or some days to the date the child will be 6 complete months? Okay, that's a very good question. I'll use an example. Now, supposing your child is born on January 1st, what time will they complete their 6 months? We are saying complementary feeding should be started at 6 months. But what do we mean? This is what we mean. So 6 months will not end at the beginning of January, of June. That is the 6th month. If the child has been born on 1st January, 6 months will end at the end of June. That is June 30th. That is when we say now the child has completed 6 months. So literally speaking, using the example, we are going to start introducing complementary feeding on July 1st. So I hope I have answered what it means by the date of starting, the recommended one. So thank you for the questions. Eric?
Maybe one last one by Martha Nzioki. Is there any guidelines for the cerebral palsy children, since most are in the sum, and a target for discharge criteria? Wait, I don't know if you had seen that question. You can have that as a last one.
Why is it in the Q&A?
The Q&A, yeah, Q&A.
By?
Martha Nzioka.
Oh,
Yeah,
okay.
Nzioka,
Martha.
that's Nzioka.
Oh,
Sorry.
yeah, I see it. I see it.
Yeah.
Yeah, she's asking, is there any guidelines for the cerebral palsy children, since most are in the severely acute malnourished and the target for discharge criteria? Wait. Yes, Martha, that's a very good question. There is some guidelines for the child with the cerebral palsy. I cannot go into it right now because we are having a whole module which we are going to offer one of these days, a webinar, nutrition management in sick children, and it includes this. The way you handle special condition of children who have been malnourished is not normal with the other children. So there are guidelines. Actually, it is a booklet that offers, it's about 84 pages. But in short, I can say the management of malnutrition in some conditions is more complex than the normal malnutrition, because you also consider the disease that the child has. You are trying to do nutritional management of their disease together with managing malnutrition. So to answer this question, Mother, look out for webinar, which we are going to be dealing with the nutritional management or diseases in children. Thank you.
Thank you for that, Annette. And for the remaining questions, we have been able to capture them, and we are going to be responding to them. Ladies and gentlemen, thank you for joining us today. We are glad that you are part of this webinar session, and we look forward to having you in our next session, which we shall communicate. Everybody have a good afternoon or good morning, wherever you are. And before we log out, we shall be sharing the recording of the session and the slides by tomorrow. Thank you and have a good day.
Nutrition and dietetics are among the major tools for development of health and basic needs of human beings in developing countries. According to WHO, health is not only denoted as the absence of disease but a state of complete physical and mental well-being in relation to the productivity and performance of an individual. Thus, we should always aim at ensuring that every community is in good health and great nutritional status. To aid in this process, taking a postgraduate diploma professional course in human nutrition and dietetics prepared by Humanitarian Global will equip professionals with expert-level skills in this thematic area. Among the key modules and topics covered include nutrition care process. In this module, the participant will get to learn more about nutrition care process, micronutrients and macronutrients, as well as nutrition assessment and surveillance. Secondly, planning nutrition interventions. In the second module, the participant will develop more knowledge on planning a nutrition intervention, emergency nutrition interventions, and how to monitor and evaluate programs in nutrition emergencies. Thirdly, parenteral nutrition. This module will cover various topics areas such as parenteral nutrition, principles of human nutrition, feeding disorders and nutrition anthropology, The fourth module is nutrition counseling. This module will help the learner understand more about principles of nutrition counseling, nutrition and HIV/AIDS, nutrition information systems, communicable diseases and non-communicable diseases. Module 5 covers program design and research methods. In this module, the learner will get to develop more knowledge and skills on program design, research methods and how to foster community partnership in program planning and evaluation. Additionally, the learner will be trained on entrepreneurship in nutrition and dietetics. Our sixth module is food safety. The module offers more understanding on food safety and hygiene, health behavior change, nutrition epidemiology and food safety legislation. Module 7 covers clinical dietetics. In this module, learner develop in-depth knowledge in clinical dietetics, nutrition biochemistry and food microbiology. Module 8, which is nutrition in the lifespan. It provides the learner with more knowledge and skills on topics such as nutrition in the lifespan, nutrition and sports, nutrition education and geriatric nutrition. Apply for this course today by visiting our website www.humanitarianglobal.com for more details.